Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuhu. Today I'm going to talk about a very important topic as far as the ENT is concerned, and that is acute and chronic infections of the nose. In that topic, we are going to cover not only acute infections, but chronic infections, as well as chronic granulomatous diseases of the nose. So please stay with me. Thank you. Bismillahir Rahmanir Rahim. That was about infections of the nasal cavity. Now, talking about other infections and other diseases, now we come to the next portion of our nasal cavity problems: granulomatous diseases of the nasal cavity. And among that, the most important one can talk about bacterial infections in the nasal cavity. And the first one I'm going to talk about is rhinoscleroma, which is a disease endemic in the subcontinent. Rhinoscleroma is a chronic nasal disease. And its clinical stages, one can talk about the first, rhinitic, which is also called atrophic stage. The second is florid or granulation stage. The third is fibrotic or cicatrizing stage. Its symptoms vary with the location of the infection. Nasal cavity, septum, which is the most common site. Other sites of infection include paranasal sinuses, orbit, larynx, tracheobronchial tree, and middle ear. Treatment of rhinoscleroma is difficult, but still one tries, because rhinoscleroma is caused by a gram-negative bacillus called Klebsiella rhinoscleromatis and sensitive to tetracyclines and streptomycin. And tetracycline streptomycin for 6 weeks may cure the infection. Acriflavin solution in vitro killed Klebsiella rhinoscleromatis, where significant airway obstruction requires surgical excision of the atrophic passage or the stenosed portions in the nasal cavity and replacing with some grafts. Laser treatment can also treat to some extent rhinoscleroma. Talking about other granulomatous diseases of the nose and sinuses, one talks about bacterial, fungal, and unspecified causes. Among the bacterial, one has got rhinoscleroma, we just talked about. Then we've got syphilis, tuberculosis, lupus vulgaris, and leprosy. And among the fungal ones, we've got Rhinosporidiosis, aspergillosis, mucormycosis, candidiasis, histoplasmosis, and blastomycosis. Whereas unspecified cause problems, among which vagus granulomatosis and non-healing midline granuloma, also called T-cell granuloma or T-cell lymphoma, and sarcoidosis. Now, coming to the granulomatous diseases of the nose and sinuses, we've got, first of all, the bacterial ones, among which syphilis, which could be congenital or acquired. Congenital usually manifests itself within the first 3 months of life or could present around puberty as edema on the nasal septum or the turbinates, whereas acquired type of syphilis usually presents in the tertiary stage in the nasal cavity, destroying the nasal septum, leading to a saddle nose deformity. Treatment of syphilis is systemic penicillin. Okay. Talking about tuberculosis, which may involve the nose, although it's uncommon, but may be secondary to pulmonary tuberculosis. Diagnosis of tuberculosis of nose is through biopsy and acid-fast bacilli found on acid-fast staining. Treatment of tuberculosis is anti-tubercular drugs. For example, rifampicin, isoniazid, and so on. Second disease is lupus vulgaris, a slow-growing form of tuberculosis in which apple jelly nodules found in the lesions. Diagnosis through biopsy, while treatment is the same as of tuberculosis. Talking about leprosy, caused by Mycobacterium leprae, which is prevalent in India. Lesions appear on the nasal septum and turbinates. Diagnosis is made by biopsy of the lesions and finding of lepra bacilli. Treatment of leprosy is dapsone, rifampicin, and isoniazid. Now we come to the fungal infections which may involve the nasal cavities. Rhinosporidiosis. Rhinosporidiosis has been defined as a chronic granulomatous disease characterized by production of polyps and other manifestations of hyperplasia of nasal mucosa predominantly. The etiological agent is Rhinosporidium sebarii. Now, causative agent may be present in water and dust, which readily infects the nasal mucosa and matures into a sporangium, subsequently bursts to release multiple endospores, which then infect surrounding tissues. The common sites affected in patients can be in the nose, which is 78% of cases. It can also involve the nasopharynx, tonsils, eyes in 1%, skin very rare, also affects the lips, palate, uvula, maxillary antrum, epiglottis, larynx, trachea, bronchus, ear, scalp, vulva, vagina, penis, rectum, and the skin. Its gross features: lesions in the nose can be polypoidal, reddish, and granular masses. They could be multiple, pedunculated, and friable. They are highly vascular and bleed easily. Their surface is studded with whitish dots you call sporangia. They can be clearly seen with the hand lens. The whole mass is covered by mucoid secretions. Its clinical manifestations: the symptoms usually unilateral nasal obstruction, epistaxis, local pruritus, rhinorrhea, postnasal discharge with cough, foreign body sensation, history of exposure to contaminated water. On examination, one may see pink to deep red polyps inside the nasal cavity and sometimes strawberry-like appearance, which bleeds easily upon manipulation. Treatment of rhinosporidiosis is difficult, and people have tried Depson, which is the same medicine tried in leprosy, now 100 milligrams once daily for 6 months to several years. Check liver function tests and blood counts every 2 weeks. Now, surgical treatment of rhinosporidiosis. People have tried different kinds of surgeries, like, for example, laser surgery. Smaller lesions can easily be removed by a carbon dioxide laser with minimal bleeding, but larger polyps are difficult to remove, and the theoretical hazard of spreading spores in the plume and need for fumigation of the theatre later. Total excision of the polyp, preferably by electrocautery, is recommended. Pedunculated polyps need radical removal, whereas excision of sessile polyps with broad bases of attachment to the underlying tissues are sometimes followed by recurrence due to the spillage of endospores on the adjacent mucosa. Talking about other granulomatous diseases of the nose and sinuses, one can talk about sarcoidosis, venous granulomatosis, midline lethal granuloma, tuberculosis, leprosy, syphilis, coccidioidomycosis, blastomycosis, rhinoscleroma, sporotrichosis, and leishmaniasis. This is a picture of a patient whose nose has been destroyed by leprosy. Now we come to fungal infections of the nasal cavity, among which, after the first fungal disease we talked about, aspergillosis, among which Aspergillus niger, Aspergillus fumigatus, or Aspergillus flavus could be the organisms causing a kind of rhinitis in the nasal cavity. A black or greyish membrane may be found on the septum or turbinates. A fungus ball may develop in the maxillary sinus, usually in immunocompromised patients, while its treatment, surgical debridement and systemic amphotericin B. Talking about mucormycosis, which is a serious fungal infection in severely immunocompromised patients and uncontrolled diabetics, a black necrotic mass fills the nasal cavity, which rapidly spreads to the orbits, hard palate, and intracranial cavity. Proves fatal if not controlled. Treatment of it, surgical debridement and amphotericin B is the mainstay of treatment. Other fungal infections like candidiasis, histoplasmosis, and blastomycosis rarely occur in the nose. Now, granulomas of unknown etiology, among which one has got venous granulomatosis. Venous granulomatosis is a systemic disease of unknown etiology involving upper airways, lungs, kidneys, and skin. May present with a clear or blood-stained nasal discharge which later may become purulent. Granulomatous lesions destroy the nasal septum in the nose, leading to a saddle nose deformity. Glomerulonephritis. My tongue. I'm catching my tongue. Glomerulonephritis occurs in the kidneys and cavitating lesions in the lungs. Nasal biopsy proves the diagnosis. Its treatment, cytotoxic drugs like cyclophosphamide and azathioprine, as well as systemic steroids, are effective. Talking about T-cell lymphoma, which was also called midline nasal granuloma in early days, destructive lesions in nose, upper lip, oral cavity and sometimes orbit may occur in this kind of disease. There is no systemic spread, while its treatment is either radiation or radiation combined with chemotherapy. The last but not the least, granulomas of unknown etiology, sarcoidosis. It's got a known etiology. Nodules resemble tuberculous lesions without caseation. Involves the lungs, lymph nodes, eyes and skin. X-ray chest shows pulmonary infiltrates with hilar lymphadenopathy, submucosal nodules over the inferior turbinate and nasal septum occur in this kind of disease. Treatment of sarcoidosis is systemic steroids. Sometimes nasal steroid sprays are also helpful. Thank you very much.